Dziękujemy bardzo. Esteemed jury, dear students, on behalf of the Student Scientific Society of the Medical University of Silesia, I would like to warmly welcome you to the session of Systematic Reviews and Meta-Analyses. My name is Jakub Figler-Rudol and I have the honor of moderating this session. I would like to cordially welcome the esteemed jury and thank you for your time and attendance this year. The order of the presentation will be slightly changed, as mentioned, as shown in the beginning. And I'd like to kindly remind the esteemed jury that if you are the supervisor of a paper, you should not assess the paper. We will judge the paper based on 4 criteria, which is scientific value from 1 to 5 points, 5 being the most points awarded for the paper, the way of presentation from 1 to 5, as well as the discussion from 1 to 5, and own contributions of authors from 1 to 5. And I'd like to begin with the first presentation now, which is titled Stem Cell Therapies in Type 1 Diabetes, Comparing MSC and HSC Approaches.
Hello, my name is Magdalena Moritz and I would like to present the results of the review Stem Cell Therapies in Type 1 Diabetes, Comparing MSC and HIC Approaches. I don't know if someone will change the slide. Okay, thank you. So, type 1 diabetes is an autoimmune chronic disease that is developed as the result of the destruction of pancreatic beta cells by the immune system. The number of people diagnosed with type 1 diabetes is increasing worldwide, making it a significant health issue. Type 1 diabetes is associated with the serious complications and may even lead to death. The traditional therapeutic approaches, such as pancreas or islet transplantations, are limited by the donor shortages, the complicated procedures, and limited long-term graft survival. Approximately only 58% of the grafts are still available after 5 years. And because of those reasons, the scientists started to look for the alternative therapeutic approaches, such as cell-based therapies. Next slide, please. So, in this review, the 17 studies have been analyzed. Next. The most important criteria for evaluation were safety and effectiveness. Next, please. The most commonly used cells in the analyzed studies were autologous cells. Next. Derived from the peripheral blood. Next, please. Mesenchymal stem cell therapies support the treatment through the immunomodulation, including inhibition of overreactive T cells and production of anti-inflammatory and including the production of anti-inflammatory and anti-apoptotic agents. The cells were derived from the different sources, like fat cells, fat tissue, Wharton's jelly, or umbilical cord blood. All of these therapies were evaluated as safe, with the most common adverse events being nausea and vomiting. Next slide, please. 3 parameters have been analyzed in all of those studies: glycated hemoglobin levels, C-peptide concentrations, and insulin requirements. In a healthy human body, the glycated hemoglobin levels should not rise above the 5.7%. The patients the results of the patient that we analyzed are, well, varied. varies. In the majority of the studies, the glycated hemoglobin levels decreased in the overview. In 3 out of 10 studies, first we see the decrease in glycated hemoglobin levels, then the increase, which may suggest the necessity of the repeated treatment. Next, please. So in a healthy human body, the C-peptide, first the proinsulin is created, and then it is divided to the insulin and C-peptide in 1:1 ratio. So if you want to know how much insulin someone produced, we need to check the C-peptide concentrations. So for the majority of the studies, the C-peptide concentrations did not differ significantly. Did not differ significantly. Only in 2 studies we see a statistically significant increase of the C-peptide concentrations. In few studies that the C-peptide concentrations decreased, this decrease was smaller and slower in the comparison to the placebo groups. Next slide, please. Okay, so insulin requirements was closely related to the changes in C-peptide concentrations. As the C-peptide concentrations increased, the insulin requirements decreased. Insulin independence was achieved only in 5 patients for 4 months in 2 out of 10 analyzed studies. Next slide, please. So, hematopoietic stem cell therapies are based on resetting the immune system by eliminating the autoreactive lymphocytes and allowing the immune system to rebuild itself from the hematopoietic stem cells in the completely new environment. So, first, the hematopoietic stem cells were collected from the patients, mainly through apheresis and peripheral blood. Then the chemotherapy was administered to the patients to destroy the bone marrow, destroy the immune system. And after that, the hematopoietic stem cells were reintroduced to the patients. Although all of those therapies were also evaluated as safe, they were also associated with the most serious adverse events like pneumonia or late endocrine dysfunctions due to the intensive chemotherapy. So, in all of 3 analyzed parameters, in the majority of the patients demonstrated the statistically significant improvement that was maintained until the end of the follow-up period or for at least a few months. Next slide, please. And in 5 out of 7 analyzed studies, between 44 to 87% of the patients achieve insulin independence from a few months until to even 4 years. Next slide. And next slide, please. Okay. In the conclusion, the cell-based therapies in type 1 diabetes aim either to immunomodulate or reset the immune system. The therapeutic outcomes depends of the patients, of the disease duration, of what cells we will administer to the patients in which quantities. Mesenchymal stem cell based therapies rarely the patient that was administered the mesenchymal stem cell based therapies rarely achieve the insulin. No need for the insulin, but their parameters were improved. And next slide, please. Hematopoietic stem cell based therapies have the highest rates of the insulin-independent patients, but those therapies are also associated with more serious adverse events. And now, in the last conclusion, we need more cell-based therapies to improve protocols and give patients the best care that we can. Thank you.
Thank you very much, and we'll now have a discussion. Are there any questions?
Congratulations. Why did you choose this subject? Because of science fascination or maybe the practice needs?
Well, I myself have type 1 diabetes, and when I grew up, first I wanted to be the doctor to treat the type 1 diabetes, but after that I thought, maybe it's better to do something in the laboratory with the cells. And then I started to read about this, and I just fell in love with this topic.
Congratulations from me also. And can I ask you about your own active part taken in this research? What did you do by yourself?
So I read all of those articles. I collected data. I made the presentation. Basically, all of that.
Thank you for your interesting presentation. I have a question related more to the methodology. The thing that I haven't seen in the presentation, what is used to be seen in the meta-analysis or reviews, is the strategy of searching words for the specific papers. So could you tell us a bit more about which words have you used?
Okay, I thought the keywords were included in my presentation, but maybe I didn't include them. 1 minute, please. I used the type 1 diabetes cell therapy and insulin producing cells in my for my keywords, and I mainly use the PubMed and the clinical trial gov.
Okay, thank you. How did you extract data for those specific detailed results?
So first, I've just read the abstract to know if this study is good for me. Then the study needed to be done on humans, no animals. It needed to be completed. It needed to use the type of cells that I needed to be. So I've read all of that articles and selected 17 that were okay with my topic.
I believe that you a little bit misunderstood my question. However, thank you so much for the presentation. Thank you.
Okay, thank you.
Okay, thank you for your presentation. I'd like to invite the authors of the second presentation titled Oral versus Topical Administration of Vitamin B in Dry Eye Diseases, a meta-analysis.
Thank you very much. Can I move my own slides?
Thank you very much for the floor. When you stare at a screen... Hello, can I just try out the microphone?
Okay.
Thank you for the floor. When you stare at a screen for too long, you may experience a burning, itching under your eyelid. Blink twice and it goes away. Yet in some patients, it can transform into a chronic issue, known as dry eye disease, or DED for short. At first glance, the treatment is simple. Ocular lubrication containing sodium hyaluronate, and you're cured. But truly, alternate therapies for DED and their implications are far more than meets the eye. First of all, DED is a complex issue that can be affected by a plethora of factors, ranging from underlying autoimmune disorders like Sjogren's syndrome to air pollution. But specifically for the purposes of this presentation, I'd like to draw your attention to two possible etiologies, being chronic eye drop use and UV radiation. Given these varying etiologies, we must wonder, what is the common pattern mechanism uniting them? It was found that in dry eyes there are elevated levels of reactive oxygen species, and this oxidative stress will decrease mucin production in goblet cells, making tears hyperosmolar, less stable, leading to the feeling of dryness and itchiness, whereas corneal epithelium under oxidative stress will start to release pro-inflammatory factors like tumor necrosis factor alpha, increasing inflammation and thus creating a vicious cycle. Thank you. That can further aggravate the symptoms of DED in patients. So if oxidative stress is the culprit, what is a possible solution? Vitamin B12 or other antioxidants are commonly used, and vitamin B12 is commonly used in topical eye drop form. But it doesn't have to be the case, because despite being a fantastic raw scavenger, it has one potential downside, being it undergoes photodegradation. Under UV light, around 10% of the sample will degrade every half hour, and it can both limit its antioxidant capacity, but also it can create toxic byproducts like formaldehyde, which will further jeopardize the situation on the ocular surface. Thus, there is emerging evidence for other uses, other modes of administration of vitamin B12 for dry eye disease. So the aim of this paper was to investigate to what extent the route of administration of vitamin B12 will determine its therapeutic success in DED. To answer this question, I decided to run a meta-analysis. The first step was a literature review in PubMed, which included the intervention being vitamin B12 administration and different clinical measures of DED. The most important one was Ocular Surface Disease Index, or OSDI for short. The inclusion criteria included only randomized controlled clinical trials in humans that administered DED patients with vitamin B12 on topical or oral form. And then the improvement in symptoms or not was measured by subjective patient-reported scales. The most important one was OSDI. And additionally, the paper had to be fully available and written in English. Thus, 26 papers were originally found in PubMed, and 25 were retrieved, and ultimately only 4 met inclusion criteria. These studies dealt with an adult population and had a pooled population of 379 participants, including 190 in the experimental group. Gender and race didn't differ significantly between these studies. But it's important to note what did differ, and these studies use complex formulations of the therapeutic agents, probably leading to a high heterogeneity we'll see in the results. And nowhere is this more important than in the case of the Fonanolow and Associates study, which used benzalkonium chloride in the eye drop formulation. And this chloride actually is a known eye drop preservative that actually is an inductor of oxidative stress, which underlines the importance of paying oxidative stress in mind when looking at the dry eye disease. Moving on to results, topical administration was not found to be statistical in treatment, whereas oral administration was found to bring about statistically significant decrease in symptoms. Overall administration by any route was not found to be statistically significant, and there was a very high heterogeneity found, which underlines the need for more studies using uniform, simple formulations. Also, a study bias analysis was done, but given there are only 4 studies included, a funnel plot was not a particularly reliable method. But so overall, we've established that the results say that that oral analysis may be successful for dry eye disease. And the question arising is, how come a systemic approach can at least rival a topical targeted solution? So apart from the photodegradation issue we've already talked about, I would like to highlight a few issues. For example, eye drops will provide the patient with a feeling of lubrication relief, but they will have a short time of contact with the corneal epithelium due to the high turnover of tear film. At the same time, bioavailability of vitamin B12 in eye drop form is unknown. In comparison, oral administration will allow for likely a higher dose, a higher bioavailability, but also storage of additional material in the liver. And actually, this building up of internal reserves of vitamin B12 may be responsible for a case of medical serendipity, because patients who suffer from the Sjögren's syndrome-associated DED have 4 times the chance than the general population to be deficient in cobalamins. And when these patients, via oral administration, have their internal deficiency treated, they will experience double the improvement in DED symptoms compared to their non-deficient counterparts. But no matter if a patient is deficient or not, vitamin B12 is more than a raw scavenger. It has different pleiotropic effects. For example, it will enhance nerve repair, which is a problem sometimes associated with DED, but also explains why it was used for different studies concerned with neuropathic ocular pain. But at the same time, it will protect the electron transport chain, acting upon the mitochondria, making energy production more efficient, but also decrease the generation of reactive oxygen species and quench the pathomechanism of DED at its very core. So overall, vitamin B12 administration via the oral route is a possible therapeutic strategy for DED, but in future studies, it is crucial to assess why such a high heterogeneity arose, but also explore those additional research niches like bioavailability, photostability, and the pleiotropic effects. Truly, the administration of cobalamins is far more than meets the eye. This presentation was done in reference to the following studies, and I thank you for your attention, and I'm open to all questions.
Congratulations, excellent job. Did you find something surprising you during this research?
First of all, because originally this paper is kind of a preparation for cell line studies I would like to perform. But originally I was very surprised about the specific niches and how little known is known about vitamin B12, because originally I was interested in digital eye strain and specifically have high visibility energy light, high energy visible light, and from this and from the idea of photodegradation and how little is known about it, I started digging deeper and deeper and deeper into alternate modes of administration, and this is how I found this topic. But what I would say is the most interesting is that how common this disease is, how it can affect different populations, from people like me who just stare at a computer for too long, to patients who, for example, undergo LASIK surgery or have iatrogenic DED.
Did you found any relationship between maybe the longevity of work, or who is suffering from the lack of cobalamin or from the lack of B12?
Right. So typically, vitamin B12 deficiency in of itself is quite rare. Around 4-5% of the general population have it, and there are of course more drastic symptoms like anemia, megaloblastic anemia. And yes, but overall, people who have issues with their nervous systems will exhibit those similar results. This is a very good topic to study, specifically the relationship, for example, between computer use or stress, and that specifically. But overall, I have been able to just find the populations who are typically elderly and sometimes suffer from type 1 diabetes. This is also a link that I found, but definitely this is a topic to learn more from.
So we're waiting for the results.
I think it corresponds with the question of jury, but I was wondering if you considered other confounding factors.
So sometimes the populations, apart from, the most important factor, in my opinion, was the formulation. Then the patients sometimes had very had some underlying conditions. Sjogren's syndrome is one, an autoimmune disorder, but there is a high rate of patients with type 1 diabetes. And I think one study that was included compared patients who actually had iatrogenic DED specifically. So of course, comparing patients who underwent surgery and thus had the symptoms, for example, the gravity of those symptoms and thus the rate of their recovery and the improvement of the symptoms may be unequal in this case. Yes, so I agree.
You are very aware of your, limitations of the study, so this is a good direction.
Thank you very much. And is it okay if I add one thing more, just as a comment? So the future studies and directions, apart from just addressing the issues and the limitations of the studies performed, is that vitamin B12 not only can be a primary treatment, but actually it could be thought about as a supplementary therapy, or we could go in the direction of synergistic therapy, because it's also an issue of how it supports proliferation. And thus, if megadoses, for example, of vitamin B12 could be actually harmful for the patient in some cases, especially as they will not be targeted anymore in eye drop form, but actually have a systemic effect on them, right? So it's a topic we can learn a lot from, right? Thank you. Thank you very much for your attention again and for your questions.
Thank you. I'd now like to invite the authors of the next presentation titled AI in Thyroid Ultrasound, a Systematic Review.
Dear ladies and gentlemen, I welcome you, dear committee, I welcome you. Today I would like to present my AI in thyroid ultrasound, bridging technology and clinical experience, a systematic review based on my paper. First, I would like to ask you a question. How many of us used AI in the past 5 days? Yes. If I would have to take a guess, I'd say most of us. And as you can observe, AI has become, and actually is still increasingly becoming, a big part in our lives, becoming a tool used by many of us on a daily basis. It also happens in medicine, because AI is a really powerful tool that helps to improve our naked eye and helps physicians to examine patients faster and more efficient. Let's look at why this matter in our daily clinical practice. Thyroid nodules are actually incredibly common and are affecting up to 60% of adult population, yet over 90% of the thyroid nodules are benign. Currently, ultrasound is the main diagnostic tool, but it has one flaw. It is really operator dependent. This dependency is the main reason of the significant diagnostic issues, like diagnostic variability, unnecessary biopsies, and patient anxiety. With this problem in mind, our research had 3 primary aims. First, we analyzed the diagnostic performance. We compared specificity and sensitivity of artificial intelligence systems compared to junior and senior physicians. Second, to evaluate the impact of clinical experience by comparing how junior and senior physicians interacted with artificial intelligence. And third, we focused on the longitudinal growth of AI technology, and especially we focused on 2 papers between 2020 and 2025. For our methodology, we designed a strict framework based on the PRISMA guidelines. We conducted a systematic review using PubMed database, and we focused on keywords like AI, thyroid, and S-Detect system. This resulted in us including 30 English language original and review articles that met our inclusion criteria. But also we actively excluded articles that lacked adequate methodology, weren't in English or Polish language, and ultimately we compared a multi-year data analysis with 2 papers from 2020 and 2025, comparing S-detect system. Let's examine the exponential growth of AI. As you can see, in 2025, the sensitivity compared to 2020, sensitivity increased by 6.7 percentage points, going from 91.3% to 98%. Let's look at the specificity. By 2025, from 2020, the specificity increased by 2.8 percentage points, going from 65.2% to 68%. Yes, I talked about the numbers, but how does this technology affect humans using it? This brings us to one of our most striking findings, which we term the educational lift for junior physicians. We conducted that AI serves as a powerful decision support system. And when looking at junior specificity trend between 2020 and 2025, we saw a massive leap. This leap was an increase by a very big number, 15.4 percentage points, and going from 37.5% to 52.9%. The clinical outcome of this lift is a massive reduction of unnecessary biopsies on patients. However, the story changes when we look at the senior practitioners, leading to what we call the senior paradox. Among senior physicians, the introduction of AI actually led to a decrease in specificity by 5.8%, going from 75% to 69.2%. The key insight here revolves around trust and habits of senior practitioners. Established clinical practices combined with the black box nature of AI often led experts to prioritize their own clinical intuition over the algorithm's suggestions. So how do we bridge this gap? The evidence points directly to a gold standard. This gold standard is the hybrid model. Our findings suggest that the most effective clinical approach is not replacing the physician, but implementing a hybrid model where a physician works with the AI. In this case, AI acts like a safety net with a sensitivity of 98%. It can easily detect any malignant lesion. But where is a human practitioner in everything about this? The human provides context, clinical intuition, and humans can provide clinical complex, can lead patients in clinical complex situations, whereas AI cannot do that. In our critical discussion, we must weigh the benefits against the barriers. On the positive side, AI significantly standardizes ultrasound interpretation. It reduces, as I said, operator dependency and turning subjective ultrasound images into more objective, reproducible data. However, we must also acknowledge the limitations. There is a risk of bias across studies and a narrative design in some of the literature. Most importantly, the black box challenge remains a significant hurdle, limiting the clinician trust despite the high performance of the algorithm. To conclude and look at the future horizons, AI has now reached an expert level as a screening tool, becoming an impressive 98% sensitivity rate. It holds immense educational value for junior doctors and junior physicians who can practice on AI models and become better doctors in the future. Moving forward, the hybrid model clearly stands as the most effective clinical solution for reducing unnecessary biopsies while maintaining patient safety. Thank you, and I invite you to ask any questions.
Congratulations. The most interesting point is the massive reduction of this unnecessary biopsy. How they calculate it and make sure that it is unnecessary? In this article that you cited.
Yes, so the higher the sensitivity rate of maybe the diagnostic tool or even human physician, the lower the risk that there is a malignant lesion. For example, there is a term false positive result where you are healthy, but the doctor tells you you are not. That means the biopsy is not needed. And therefore, the higher the sensitivity rate, as I said, the AI has a whopping 98% sensitivity rate, the lower the risk your biopsy is needed.
Congratulations. Professor, do you want to ask any more question, or can I ask mine? Okay. Congratulations. I wanted to ask you about the AI-supported diagnosis in junior and senior clinicians. And tell me, what do you think? Because I have some experiences in older experts, doctors doing their job, that in most cases they are diagnosing more complicated, for example, nodules or biopsies that they are performing. Do you think that maybe AI is taught only on the basis of more common cases, maybe those cases that are really rare and not really popular and very common? Maybe they need just more experienced senior research. Did you find any relationship between those types of doctors and procedures done?
Yeah, so thank you for your question. It's very interesting, and I myself have been to USG practice, and I think it's a real tough job for a physician to accurately diagnose a patient in real time, because the probe has to be in a particular angle. The diagnostic image is not always the biggest resolution. And coming back to your question, why is AI not a great tool right now, maybe in the future? I think it's the problem with explainable AI, because right now we have a model that presents a doctor with a data, but the doctor doesn't know where this data comes from. So the doctor doesn't know the background thought process of an algorithm. And that's why this senior paradox that I mentioned happens, because doctors trust their intuition and they don't trust results they don't understand. That's why I think future improvements to AI are needed.
I have as well a question, but to not make a mistake, I would like to see one of your previous slides. If it's possible, could you open the slide with the results? Further, please. Further. Oh, okay. So the previous, because you are talking about the improving the specificity or sensitivity across the periods from 2020 to 2025. So I was wondering, because maybe I misunderstood something. To assess sensitivity and specificity, we need a gold standard. So we need basically two diagnostic tests. The first diagnosis performed by probably young physician, and something that verify his decision and proves that we are having a disease here for sure, almost 100% specificity and sensitivity. So in that case, I was wondering, how did you study the improvement? Okay.
Yeah, so first let me start from the difference between sensitivity and specificity. Why the specificity was so much lower, 68%, from the sensitivity, 98%. It's like 30% slower. That's because sensitivity only takes into consideration if a patient is ill or not. But why is specificity so much lower? Because AI doesn't really know a difference between a benign and a malignant lesion. That's why AI can tell a physician that this lesion or nodule, thyroid nodule, is malignant, but in reality it's benign. So that's why the specificity is so much lower.
So that means that in both cases, physician always used AI.
Yes. And I think, let me answer to your question, what is a gold standard? For me, a gold standard in a specific sensitivity is if AI is right or wrong. In 2020, AI was right 91.3% of the time, and in 2025, AI took a huge leap. As you can see in the, I don't know, everywhere. We used every day AI now, but 5 years ago, no one even thought of AI.
But there was someone who verified AI, for sure. Thank you.
Thank you very much.
Thank you very much for this presentation. The next presentation will be presentation number 3 on the list, titled Clinical Advances in COPA Syndrome and Pediatric and Adult Patients. So this will be presentation number 3.
Dziękuję bardzo. Halo, halo, słuchać mnie? Dziękuję. Good afternoon, my name is Jan Kinasiewicz, and together with my colleagues Szymon Szlęzak and Karolina Kaleta, we prepared a presentation about the clinical advances in COPA syndrome in pediatric and adult patients. Our work's tutor is Dr. Kacper Packi. And what is a COPA syndrome? It's a rare autoinflammatory disease with autoimmune component. It follows a autosomal dominant inheritance with incomplete penetration. It was first described in 2015, and it follows a classic triad of symptoms: interstitial lung disease, arthritis, and immune complex nephropathy. Pathologically, it belongs to type 1 interferonopathies, and the age of onset is striking. About 76% of patients start their symptoms, develop these symptoms before age of 5, with full spectrum being from infancy to 50 years old. And the pathogenesis of COPA syndrome. The COPA gene encodes the COP1 subunit of the COP complex. It's responsible for the retrograde transport from the Golgi apparatus to the endoplasmatic reticulum, and when there are mutations in this gene, and they happen most frequently in the WD40 domain, being the 8th to 10th exon of the COPA gene, and C-terminal domain mutations. When these mutations happen, It causes the retention and overproduction of the sting, which leads to constant stimulation of IR3 and F-kappa beta factors, leading to overproduction of type 1 interferon and other pro-inflammatory cytokines, leading to multi-organ inflammation. And the methodology of our study, we searched the PubMed and Pure PMC databases for the third term COPA syndrome. We excluded our duplicates, population mismatch, and we include the studies talking about the clinical manifestation in children, adults, treatment, and diagnosis of COPA syndrome. And what are the clinical manifestations in children? As I said before, the classic triad follows the lungs, joints, and kidneys diseases. And for the lungs, it differs from diffuse alveolar hemorrhage to ILD with irreversible fibrosis and cyst formation. For joints, there's characteristic non-destructive Jacquot type hand deformities with presence of antibodies, rheumatoid factor, anti-CCP, and ANA. And with these antibodies and this clinical scenario, there are many false diagnoses of juvenile rheumatoid arthritis in children with COPA syndrome. And for kidneys, we have glomerulonephritis requiring constant monitoring. And clinical manifestation in all age groups. There's a graph from the work of David and his colleagues, and he shows that the ILD is present 82% of all cases, joints involvement is 68%, skin in 32%, and kidneys in 18% of all COPA cases, syndromes that he screened. And they deducted the three clinical scenarios that are possible. First one being childhood onset recognized later, second one being late onset, and third one being asymptomatic carrier that belongs to about 25% of all cases. And what is the diagnostic approach that we think clinicians should follow? First, we start with clinical suspicion. If we see atypical arthritis, ILD, and autoantibodies in a patient, we should think about COPA syndrome. Then we should perform the NGS, a test of the COPA gene, focusing on WD40 domains and C-terminal domains, because there are the most frequent mutations. Additional tests are the type 1 IFN signature, high-resolution chest CT, and serology laboratory tests. And the good diagnosis leads to early treatment. And the early treatment, there are treatments for acute phases and the chronic phases. For acute phases, we use high dose of glucocorticosteroid pulses and mycophenolate mofetil for renal involvement and steroid sparing therapy, especially in children. And the most important drugs are the JAK inhibitors, being baricitinib and ruxolitinib, because if we start them early, they can achieve rapid arthritis remission, lung stabilization, possible aggression of ILD, all if started early. So the early diagnosis leads to much better outcomes and much better prognosis. So our conclusions are to recognize early atypical arthritis, ILD, we should consider COPA syndrome. Confirm through genetic testing, treat early with type 1 interferon-targeted therapy, and protect irreversible organ damage, prevent. Thank you very much for your attention, and I'm waiting for the questions.
Preparing this job, congratulations. Did you use any classic book or paper, classic paper, but that only this electronic version?
We used only publications from public databases. So the syndrome is rather new. It has only 10 years of history. So we wanted to focus on new informations, and when, I don't know if I talked about it, but when searching the Europe PMC database, we focused only on the last 5 years of the publications, just so those old records, we don't acknowledge them.
Congratulations. If I can ask you, because the first time I can see Jan Długosz University in Częstochowa. Yeah. Congratulations, you are the new university, and you are the student of the fifth year?
Fourth year.
Fourth year. Wow, congratulations. So you're doing a lot of good job. That's
thank you very much.
Good for us, and thank you for letting me know about COPA syndrome. Thanks.
Yeah, I'm as well a little bit surprised that you are talking about something what is, as you said, suggested 10 years ago, and there are no any yet recommendations. So I'm surprised, to be honest.
So I want to acknowledge that I learned about this syndrome doing this paper, because our tutor is interested in immunology and he was our immunology teacher. So I thought we should search for some new cases or some new syndromes to write about in our student association. And I've learned about the COPA syndrome, and now I know, I think, quite a bit.
Thank you.
Thank you very much. No, I haven't met any patients. This is a review paper, so we don't have any patients with those with this diagnosis. But I think it's really interesting for me that I've never heard in pulmonology or rheumatology classes about it. But I think it may be a diagnostic problem.
In your present work was 3 authors. What is your contribution in this work?
So we together screened all of the papers, and we divided our paper into 3 sections, being the diagnostic, being the genetics, and being the clinical genetics, pathophysiology and pathogenesis, and clinical manifestations. So I was the one being writing about the pathogenesis of the COPA syndrome, and my colleagues Carolina and Szymon were from the genetic side and from the clinical manifestations.
Okay.
Thank you very much.
Thank you very much. The next presentation will be presentation number 7, stereotactic radiosurgery for optic pathway gliomas.
Hello. Can you hear me? Could you maybe share the screen so I can take control and change the slides myself, or should I ask you to do it?
Please, could you share the presentation yourself?
Okay.
Tak? Dobra.
Dobra. Słyszałem numer 7, tak? Numer 7. To przepraszam, bo ja tam widziałem po prostu. A nie, to przepraszam. A comprehensive to jest numer 9. Dobra, sorry. Dobra, nie, to co ja przepraszam. To jest co, tak? Nie, czekaj, inne. Sorry, ja mam tutaj, sorry, to było 8. Przepraszam. Czekaj, to klasycznie. Nie, to 10, jeszcze 2. Spokojnie.
Okay. Hello. Are you able to share the presentation?
Should I share it on my own screen?
Yes, please, if you can.
Okay, 1 second. I didn't understand. I'm sorry. Wait a second, please.
Number 3 and number 4 are the same.
15 topics, because there's two that are the same and two people cancelled.
Can you see it?
Yes, we can see it. Can you? Yes, okay, you can. Thank you.
Okay, sorry for the delay. Hello, esteemed jury and colleagues. My name is Matei George Ilie. I am a third-year medical student from Iași, Romania. And today I have the honor of presenting our systematic review about stereotactic radiosurgery for optic pathoid gliomas to you. This is the plan of my presentation. And I will begin with a brief overview of optic pathways, gliomas, and the rationale for stereotactic radiosurgery. So, firstly, optic pathoid gliomas, or OPGs, are rare low-grade tumors involving the optic nerve, chiasm, and tract. Historically, some lesions were thought to behave like hamartomas because of their indolent evolution. However, histopathological evidence has shown they are true neoplasms. Their management remains challenging because treatment must preserve vision and hypothalamic function while still achieving tumor control. Standard treatment today involves surgery or chemotherapy, but stereotactic radiosurgery, or SRS, offers highly focused radiation, sparing adjacent neurovascular structures. This precision is extremely important near the optic apparatus, where excessive radiation exposure may lead to permanent visual deficits. And for this review, we focused on single session gamma knife surgery, which offer a high precision alternative to fractional radiotherapy. I will now present the main objective of our systematic review. The aim of this study was to assess the efficacy and safety of stereotactic radiosurgery in optic pathoid gliomas, focusing particularly on tumor control and preservation of visual function. The next section focuses on methodology and literature selection using PRISMA guidelines. So for this review, we conducted it as a systematic review according to the PRISMA guidelines, and the PRISMA framework ensured transparency, reproducibility, and methodological rigor throughout the review process. Following this standardized methodology, we performed a comprehensive search in PubMed, Scopus, and Web of Science to identify studies evaluating stereotactic radiosurgery for OPGs. Our search strategy focused particularly on gamma knife radiosurgery and related stereotactic techniques. All retrieved records underwent a structural PRISMA screening process involving duplicate removal, title and abstract screening, followed by full text eligibility and assessment. We included studies published between 1990 and 2026 involving patients diagnosed clinically or radiologically with OPGs treated using SRS. Eligible studies needed to report oncological or functional outcomes and involve human subject. We excluded non-English publication, laboratory or animal studies, conference abstracts without full text, duplicate studies, and articles without outcome data. For each included study, we extracted detailed information regarding study design, patient demographics, tumor location, radiosurgical modality, radiation dose and fractioning, progression-free survival, visual outcomes, endocrine complication, and radiation-induced adverse effects. After identification from database, we started with 95 studies. We removed duplicates before screening and were left with 83 studies. After excluding studies not related to OPGs, SRS, or gamma knife, the number went down to 25. In the end, after assessing for eligibility, the final number was 9 studies for this systematic review. Because the included studies demonstrated substantial heterogeneity regarding treatment protocols and outcome reporting, a formal meta-analysis was not feasible. Therefore, we performed a qualitative synthesis of the available evidence. I will now discuss the main results of this review. Our review demonstrated favorable oncological outcomes following stereotactic radiosurgery. Recent studies reported local tumor control rates reaching up to 92.3% in recent single-center series. while 5-year progression-free survival in pediatric cohorts was approximately 83%. Most patients achieved stable disease after treatment, although some demonstrated measurable tumor volume reduction. Importantly, smaller tumor volume at the time of radiosurgery was associated with better local control and lower risk of edema. Visual preservation remained the most clinically relevant outcome across the included studies. Visual stabilization or improvement was achieved in approximately 80 to 91% of patients after SRS. Visual improvement was observed in nearly 1/4 of patients, particularly when treatment occurred before severe visual deterioration. Late visual decline was uncommon and more frequently associated with tumor progression rather than radiation toxicity itself. The final section focuses on treatment safety, clinical implication, and conclusions. One of the most important aspects of SRS and gamma knife is balancing tumor control while protecting the optic apparatus. Most studies suggested that margin doses between 10 and 12.5 gray provide optimal balance. And at the same time, maximum dose to the optic nerve and optic chiasm should ideally remain below 8 to 10 gray in order to reduce the risk of radiation-induced optic neuropathy. In conclusion, gamma knife SRS is an effective salvage treatment for progressive OBGs. It provides high local tumor control rates with relatively low toxicity while preserving visual functions. Careful patient selecting, precise dosimetric planning, and long-term ophthalmologic and endocrine monitoring should remain essential. However, additional prospective multicenter studies are still necessary to better define the role of stereotactic radiosurgery in optic pathways gliomas management. And to end it, these are the studies we used for this review, and thank you all for your attention. I'll be happy to answer any questions.
Thank you very much. We'll now proceed to the discussion.
Thank you for presentation. Congratulations on the results. How much time did you use for preparing this research?
We started it this winter because we're all part of a student surgical association in Iași, and we organized a student camp for neurosurgery, and we worked with the doctor, with Răzvan Cristian Buga, which is the lead physician in gamma knife in our hospital in Iași, and he asked us, because we were there for a long time and we had a lot of breaks, and we asked him if he could help us do something more than just schoolwork. So the basis of this review were laid this winter, and we work from time to time between our exams, finals, and all the other work we had.
Okay, thank you. This is all.
Okay, thank you.
Thank you. And now I'd like to invite the authors of the next presentation, titled Unmasking a Rare Endocrine Channelopathy, a systematic review of CAC NA1H related primary aldosteronism.
Good morning. Can I be heard?
Yes. Could you, because you're an online participant, can you share your presentation from
yes,
your
of course.
account?
Yes, of course. I'm doing it right now. Oh, I hope that I need to disappear from the... Rozdziel wideo. O, teraz. O, chyba teraz jest OK. Okay, so can we start?
Tak, proszę zaczynać.
Okay. So, ladies and gentlemen, welcome. My name is Wojciech Michalski, and today I would like to present to you the results of our systematic review about a rare endocrine channelopathy, a familial hypoaldosteronism type 4. Let's get started. Physiologically, aldosterone maintains homeostasis by promoting sodium retention and potassium excretion. Autonomous overproduction leads to primary aldosteronism, causing severe hypertension and hypokalemia. Crucially, aldosterone excess is a direct cardiovascular toxin, significantly increasing the risk of major cardiovascular events. Because of this high systemic risk, we rely on a three-step diagnostic scheme. Initial screening using the aldosterone to renin ratio, followed by confirmatory testing, and finally subtype classification to determine the appropriate treatment. While PA is the leading cause of secondary hypertension, over 90% of cases are sporadic, caused by localized somatic mutations in adrenals. However, a small subset of patients inherits the condition through systemic germline mutations, causing familial hypoaldosteronism. As shown in Figure 1, there are currently 4 subtypes, each driven by a unique mutation. Our research focuses on the rarest, familial hypoaldosteronism type 4, first described in 2016. Let's look at FH4 pathophysiology. Figure 2 shows the structure of T-type calcium channel located in the adrenal zona glomerulosa and encoded by CACNAH. Transient calcium entry through this channel plays an important role in cell signaling. FH4 patients carry a germline gain-of-function mutation in this gene. This structural defect alters the channel, causing a prolonged pathological influx of calcium. This overload forces cells to continuously overproduce aldosterone. Because FH4 is so rare, its clinical management remains poorly defined. Literature also lacks any review about this condition. Our objective was to comprehensively synthesize the phenotypic, biochemical, and therapeutic characteristics. We conducted a rigorous systematic review following PRISMA guidelines. After screening nearly 2,000 records, we ultimately identified 11 relevant studies. Our cohort consisted of 31 fully documented symptomatic patients and 8 mutation-positive relatives. Crucially, FH4 is incredibly heterogeneous. The onset of hypertension ranges from 2 months of age up to 48 years, with severity ranging from mild elevations to extreme cases, peaking at 240 over 160. However, the laboratory profile presents a diagnostic trap. Usually, in PA, we expect an elevated aldosterone, profoundly suppressed renin, thus a high aldosterone to renin ratio. But in FH4, 30% of patients presented with normal kalemia, and some of them exhibited normal aldosterone levels. This atypical presentation can lead to a falsely negative ARR, leaving some of them undiagnosed for up to 30 years. Genetically, we identified 17 distinct CACNAH mutations scattered across the entire channel structure, including 2 intronic mutations, proving there is no single mutational hotspot. Furthermore, our screening revealed an incomplete penetrance. Relatives carrying the exact same pathogenic mutation, including a 12-year-old boy and a 70-year-old woman, remained completely asymptomatic with normal blood pressure and potassium. Because of this, multi-gen next-generation sequencing panels are essential for definitive diagnosis and family screening. Anatomical diagnosis presents another clinical difficulty. Over 35% of patients had completely normal adrenal glands. The rest showed a mix of unilateral or bilateral lesions. In classic PA, a dominant nodule leads to unilateral adrenalectomy, yet in FH4 this treatment is generally ineffective. Patients who underwent surgery frequently experience recurrent hypertension postoperatively, requiring the reintroduction of polypharmacy. Since surgery is ineffective, the approach to FH4 management is pharmacological. Patients frequently required polypharmacy of 3 to 4 drugs. We found that the combination of mineralocorticoid receptor antagonists with calcium channel blockers has the best therapeutic effect. Yet this presents a pathophysiological paradox. FH4 is a T-type channelopathy, yet standard blockades like nifedipine or amlodipine target L-type channels. So, why do they work? Recent studies show that L-type channels compensate to maintain pathogenic calcium oscillations. So, L-type blockers suppress this secondary overproduction. Nevertheless, targeting the primary cause requires direct T-type inhibition. While specific blockers remain clinically unavailable, modern dual L and T-type blockers such as benedipine demonstrate excellent clinical promise. Addressing this therapeutic gap through further in vivo clinical studies is the true future of FH4 management. In conclusion, FH4 is a monogenic systemic adrenal channelopathy with significant phenotypic variability and incomplete penetrance. Standard screening and imaging frequently appear normal, leaving patients with unrecognized aldosterone excess for years. To avoid this, we must prioritize multigen NGS panels for accurate diagnosis and family screening. Unilateral adrenalectomy is generally ineffective and should be avoided. Instead, optimal management is pharmacological, with dual L and T-type blockers emerging as a highly promising disease-specific option. Finally, due to atypical presentation and asymptomatic carriers, the true prevalence of FH4 is undoubtedly underestimated. We strongly encourage clinicians to report new cases to fully unmask this condition. Thank you for your time and attention.
Congratulations for your great presentation and a nice topic. I wanted to ask you about the surgery treatment. Does it really happen very often? Is it common? Did you find any occurrence of surgery therapies in those patients?
Yes, among this 31 cohort, about 6 or 7 of them had this the indication for surgery, and they had unilateral adrenalectomy, and after this they can do the histopathological examination of this tissue. But the patients often had hypertension after this surgery, so this is why we think that surgery is ineffective in this group of patients.
Of course, thank you for this information. Thank you.
Thank you very much. This is everything.
Thank you very much.
I'd like to invite the author of the next presentation, titled A Comprehensive Review of Techniques, Factors and Errors Affecting Digital Impression Quality.
Ladies and gentlemen, my name is Anna Polikarpova and I'm a second-year dental student and a member of Prosthetic Science Club in Medical University of Silesia in Zabrze. And today I would like to present our systematic review about techniques, factors and errors affecting digital impression quality. When it comes to the background of our systematic review, the intraoral digital scanners are becoming more and more common in dental practice. So we would like to see a replacement of clinical replacement of conventional impression methods in the future, because the digital workflow may improve comfort of the patients, efficiency, and as well as the communication between the dentist and the laboratories. Our systematic review was prepared according to the PRISMA guidelines. We analyzed 26 articles using PubMed, Web of Science, Scopus, and Google Scholar. We used both in vitro and in vivo studies. And here is the PRISMA flowchart showing the way of selecting our studies. And we used 13 in vitro studies and 3 in vivo studies. And here is the table showing all of the studies that are included in the main part of our a systematic review. And the aim for our review is to analyze the currently available knowledge on intraoral scanners, scanning techniques, factors influencing scan quality, and to classify scanning errors and their impact on the accuracy of the 3D model. When it comes to the scanning mechanism, most scanners are based on laser technology or structured light projection, and the light is projected onto the teeth and soft tissues, and then reflected back to the scanner sensor. Then the software system analyzes the differences between the reflected light and calculates the exact shape and the position of scanned areas. Then thousands of points are quickly collected and thousands of points are quickly collected and sent to converted into a point cloud, and here is the beginning of conversion to the 3D digital model of oral cavity of the patient. And the most used techniques in intraoral scanning are active triangulation, active wavefront sampling, and confocal microscopy. The strategies that are most commonly used in the intraoral scanning are optimized scanning, linear strategy, and sequential strategy. And there are 3 main clinical and technical factors affecting the accuracy of iOS systems. Those are operator-dependent factors, the factors dependent on patient intraoral factors, and the factors dependent on technical parameters. The operator-dependent factors are operators' proficiency in device handling, scanning range and positioning angle, scanning pattern and sequence, and protocols for cutoff points or scanning and overlapping. The patient-related intraoral factors are location of the scanned area, arch width, tooth preparation design, restorative material, surface treatment, and humidity conditions. And for the factors dependent on the technical parameters those are as listed, and the most important are ambient temperature, surface treatment, and scanning resolution. And now I would like to list the most common errors according to the factors that were listed previously. The operator-dependent errors are the most commonly the mesh hole error, stitching error, tissue error, reliability error, umbrella error, scanning noise, and ISB geometry error. When it comes to patient-dependent errors, the most common ones are humidity error, breach error, fuzzy finish line errors, and scannability noise error. And due to the heterogeneity of the studies included into our review, the performing of quantitative meta-analysis was impossible. Additionally, the studies were narrative in nature, therefore we created our own risk of bias assessment by combining multiple assessment risk of bias assessments. For the systematic reviews, we used AMSTAR2. For in vitro studies, we used QUIN, and for in vivo studies, we use JBI. Furthermore, this review is not registered in Prospero. For our results showed that intraoral scanners are very dependent on multiple factors, both clinical and technical, and in vivo conditions may limit the operator's movement, which can lead to noise errors. Interestingly, there were some studies that showed no relevant differences between scans with or without noise. However, it could prolong the scanning process. Yeah, and because of the differences between scanners, there are no. Each of the scanner must have its predetermined scanning technique and conditions, and there are no universally correct way for scanning because all of the scanners are built differently, and there is no universal protocol for that. For the clinical importance, when it comes to the clinical importance, it is the intraoral scanners may enable accurate and reproducible digital models while also reducing the errors related to conventional techniques. They may improve diagnostic and treatment planning accuracy, and also the communication between the dentist and the laboratory. And they can also improve the comfort of the patients because this procedure is usually faster and less uncomfortable. And for the conclusions, I would like to say that the effectiveness of intraoral scanners is very multifactorial, and the most important ones still remain the experience and the qualifications of the operator, and understanding the ways of scanning, the scanning strategies, the clinical conditions and possible errors may help clinicians minimize the inaccuracies and improve dental treatment. And in the future, it is very possible that dental digital intraoral scanners will become an even more important part of the prosthodontics treatment and fully digital workflow. Thank you for your attention, and I am very open to your questions.
Thank you for your presentation. Congratulations, very nice. I'm very happy to hear that students are interested in digital dentistry. This is my, my point. I love it. I wanted to ask you about something. I don't think that they will become the future, but they are here. This is the presence. This is something fantastic that happens now. And I wanted to ask you, why did you say that not all the scanners are the same, that we have different scanners and different methods of intraoral scanning and building the mesh? I think they are the same. Do you think that they are different? What I meant was the different technologies that are used for scanners. For example, the active forefront sampling, the confocal microscopy, and they are different. They differ from each other, and that's why they all have their own way for using them. And okay, that was I understand. And this is the second part of my question, because I missed a little bit of new information. I don't know, what years did you check? 2020 and 2026 that you did your research?
We chose the studies from 2018 to 2026.
2026, okay, because there was nothing about photogrammetry and intraoral scanning of implants, of digital huge reconstruction. And this is also a very interesting point, and many problems are happening with scan bodies and photogrammetry. So that would be the point to add. I think that should be added to your key points, key words. Maybe it would be more effective. But thank you, it was a very nice topic.
This kind of diagnosis using the scanning and CT is the first step to automatization of the process in dentistry. What do you think about the robotic assistance during this kind of operation?
I think that in dental world it is less. It is a very new thing. I don't think it is very. It is not common at all to use robotic assistance. I think it's more in the operational field with the with operating bodies and.
What is your personal opinion?
My personal opinion.
Possible or no? Tomorrow or after 5 years, or nothing?
I think that some procedures could be done with robotic assistance, but I don't think that robots could fully replace us, because there still should be a person who will manage the robot and who will control this and make sure that it is safe and that the robot doesn't have any issues happening with it. Thank you so much.
Thank you very much for this presentation. I'd like to invite the authors of the next presentation, titled Functional Role and Therapeutic Potential of the P2X7 Receptor in Glioma, Systematic Review.
So first things first, I'm sorry for the problems, because when I heard glioma, I was certain that it was calling my presentation. Okay, so dear audience, my name is Maciej Baron. I'm representing the Department of Pathomorphology of Medical University of Silesia. I would like to begin by describing why gliomas are a serious clinical challenge. So first, the gliomas are the most common primary tumors of the brain. Moreover, the most common type of the glioma is high-grade glioblastoma multiforme in adults. And the therapy, especially for the high-grade gliomas, is often ineffective. To prove my words to you, I would like to read you a quote from one of the studies. Here you can see it. Even with aggressive surgical resection, along with radio and chemotherapy, the prognosis from glioblastoma multiforme patients remains about 12 months. As you can see, this is the data from 2008. Nearly 20 years, and still nothing's changed. And thus, it is important to look for other points for the therapy, for some kind of a receptor maybe. And such receptor may be P2X7R. But what is P2X7R? It is a member of purinergic inotropic receptors family. It is expressed on immune cells and it takes part in inflammatory processes. And it was implicated. It also takes part in various human neoplasms, including the gliomas. And thus, the aim of our study was to clarify the biological and clinical significance of P2X7R in gliomas through a systematic evaluation of available evidence. So let's move on to our methods. So we have searched major databases and we have identified 180 studies. After the duplication, we got 96 of them. But to final analysis, we have included 41 of them. At this point, it is worth mentioning that our review has been registered in Prospero. Moreover, we have assessed a risk of bias for every included study by using OHAT risk of bias assessing tool. So let's move on to our results. Let's begin with the expression of P2X7R. So P2X7R expression has been confirmed in glioma cell lines, in glioma infiltrating microglia, or even in human glioma samples. Moreover, it was influenced by the environmental factors like oxidative stress or radiotherapy, which may be quite interesting, but we will talk about it a bit later. Right now, let's discuss an impact of P2X7R on the glioma cells proliferation. So, the activation of P2X7R had a bit heterogeneous effects. However, we get much more consistent results about the inhibition, because in vast majority of the studies, inhibition of P2X7R resulted in reduced proliferation and migration of the glioma cells. And this is something interesting. Moreover, P2X7R also took part in shaping immune environment of the tumors. So, as we said before, it is expressed on tumor infiltrating microglia, and its inhibition results in reduced infiltration.
Moreover, it takes part in shaping in secretion of pro-inflammatory cytokines like interleukin-6, 8, and vascular endothelial growth factor. So here you can see a figure which summarizes our results. I will give you a moment with this figure. And right now, let's move on to the most important part of our results, to the evidence directly from human samples. So as we said before, its expression has been confirmed on human glioma tissues. Moreover, some studies indicated that it's associated with a response to radiotherapy. Particularly, one study indicated that high expression of P2X7R on patients' tissues resulted in increased effectiveness of the radiotherapy. Moreover, plenty on ex vivo studies suggested that high expression of P2X7R on the glioma cell tissues was took part in radiotherapy. Yes, and cost much more sensitive to the radiotherapy, I'm sorry. And lastly, it also modulates the chemotherapy efficiency. And here's the interesting part, because both activation and inhibition results in increased effectiveness of the chemotherapy. So, as we said before, inhibition results in reduced proliferation of the glioma cells. On the other hand, activation of P2X7R results on the opening of the membrane parts, which results in increased penetration of the chemotherapeutics. Pretty clever, aren't it? So, let's move on to the conclusions and study limitations. So first, we believe P2X7R may be having a bit context-dependent role. Moreover, it has consistent anti-tumor effects during inhibition in ex vivo validations, and it takes part in shaping immune environment of the tumor. However, our study had some limitations. First, models were a bit heterogenic. Moreover, the majority of the studies was just an ex vivo validations. And, especially, some in vitro studies had limited in vivo validation. So, what would we recommend for the future researchers? First, I'm sorry, because here is a problem, because I don't see my graphics here, but it's okay, let's carry on them. Yes, let's come back, because there were graphics. Okay, doesn't matter. So, we would recommend to use much more standardized experimental models. We would recommend to use much more in vivo validations. And we would recommend to seek with the correlation for the clinical important mutations for the glioma, like IDH1 or 2. So thank you very much for your attention. If you have any questions, please feel free to ask. I'll be happy to answer them. Okay. So, okay.
Congratulations. Did you have any personal experience with this example of this disease as in pathopathology department as exercises or patients?
Yes, I wanted to perform an immunohistochemical study of the gliomas, and it should be just a preludium for the much bigger study for our grant. However, the problem was in our department, we don't have glioma tissues, and that was my main problem. But I think I will overcome this obstacle in the future, because right now I'm cooperating with other specialists who have access to such samples from the gliomas. That's okay.
Thank you very much. Well done.
Jednej prezentacji czy proszę, nie chcę być.
A która?
Już następna nie jest moja, po prostu.
Następna jest to?
Tak, następna jest moja, tak.
Też? Dobra.
Mam jedno pytanie tylko. Czy mogę sprawdzić, czy się wgrały moje grafiki? Bo tutaj widzę, że się nie wgrały bardzo.
Tak, a wydaje mi się, że to przez to, że to jest starsza wersja PowerPointa i może nie odtworzyć tego. No, z 2000.
Nie pamiętam. Oj, a dobra.
No, niestety, nie można...
Kurczę.
To jest starsza wersja PowerPointa.
Kurczę, mają takie ładne grafiki. Niestety. Dobrze, na przyszłość będę po prostu.
No... To sugestia na przyszłość. Niestety, no tutaj nic nie zrobię, bo starsza wersja.
No dobrze, ale już jesteśmy po prezentacji, dziękuję.
Gdzieś jesteśmy.
Jeszcze
jedną ma pan, dlatego tutaj pan został.
Bardzo nie zmęczyłem jeszcze, więc...
Tom na pewno.
Okay. So, dear audience, it's me again. I have another project, and I still represent the Department of Pathomorphology. Can I have... Yes, thank you very much. Thank you very much. So, again, let's answer the question, why non-small cell lung carcinoma is still an important scientific topic. So, lung cancer is the leading cause of cancer-related mortality worldwide in both sexes combined. Approximately 85% of lung cancer cases are non-small cell lung carcinoma, the NSCLC. However, we have a targeted therapy, and that's good news. So, the question is, why did we perform this study if we already have a targeted therapy for non-small cell lung carcinoma? Because of the resistance. Because, as you can see, up to 64% of the patients who are treated with targeted therapy will develop a resistance at some point. And thus, it is important to look for other targets for the therapy to overcome this resistance. And such targets may be VISTA and CD155. So right now, let's describe these molecules. What are they? So VISTA is a member of B7 family of immune checkpoints. It is immune inhibitory regulator, and it's expressed, has been confirmed in various human malignancies, including non-small cell lung carcinoma. On the other hand, CD155 is an actin-like family member. It is ligand to TIGIT and CD96, and is responsible for promoting the immune evasion. So, the aim of our study was to systematically assess the expression, biological role, and clinical significance of VISTA in non-small and CD155 in non-small cell lung carcinoma. So, let's carry on to our methods. So we have searched 4 major databases: PubMed, Scopus, Embase, and Web of Science. 256 studies were identified. Out of them, to final analysis, we have included 50 of them. And out of them, 29 were describing the role of CD155, and 21 were describing the role of VISTA in non-small cell lung carcinoma. So, as before, let's carry on to our results, and let's begin with the expression of both molecules. So VISTA expression was predominantly detected in immune cells infiltrating the tumor and on tumor stromal cells. Moreover, it was also detected on brain metastasis of non-small cell lung carcinoma. However, the expression was a bit lower than on primary tumor, but it was still easily detectable. On the other hand, CD155 was detected on membranes of the tumor cells, where no expression was found on healthy lung tissues, and it was often correlated with PD-L1. And just to be clear, all of the studies were performed on ex vivo samples. Okay, so both molecules had an impact on tumor immunology. So VISTA was inhibiting naive T cells transition into Th1 phenotype. Moreover, it was also activating B regulatory cells, which are responsible for secreting anti-inflammatory cytokines like interleukin-10. CD155 also suppressed T cells function, but it also was responsible for promoting anti-inflammatory M2 forms transition of the macrophages. And last but not least, the most important part of our results from the clinical perspective, the association with the prognosis. Unfortunately, we have a bit insufficient results about VISTA's role. However, the association of CD155 with prognosis was statistically significant, especially with worse prognosis, and especially with overall survival and progression-free survival. As you can see, our results are pretty meaningful because majority of the studies has a hazard ratio above 2. Some studies has even hazard ratio above 6, and our maximum hazard ratio was 6.5. And that was in study which was performed on large cohort on non-small cell lung carcinoma patients, about 300 patients. So these are pretty interesting results. And this association is particularly strong when CD155 was correlated with PD-L1. So, moving on to our conclusions. So we believe both VISTA and CD155 are taking part in shaping immune environment of the tumor. However, CD155 has consistent association with worse prognosis. However, the clinical relevance of VISTA is still a bit unclear. And that raises an important question. What next? What shall be done next by future researchers? How shall we continue this study? So we believe the future researchers and us should clarify the clinical role of VISTA and validate CD155 role as a therapeutic target. So thank you very much for your attention. If you have any question, again, I will be happy to answer them.
Thank you very much. Are there any questions from the jury?
Congrats. What is your, because we have seen several co-authors, what is your personal contribution in
Thank you very much for this question. So my personal contribution was basically everything. I was ahead of this study. I needed other authors to be, for example, second reviewer of the studies in research, to be for calculating assessing risk of bias. I needed a second author to confirm my choices, and that was the contribution of this.
Who prepared this presentation? Because it's who prepared this presentation?
It was mine. However, if you are asking about the graphics, it was performed by artificial intelligence.
Okay, thank you.
Very, very good presentation.
Thank you very much.
Very expression.
Thank you very much. Tylko, że mi się te obrazki wygrały. Pięknie to opowiada. Bardzo dziękuję. Bez obrazu.
Mikrofon panu jest potrzebny na przyszłość.
No zdecydowanie. Okay, so now I'd like to invite the authors of the next presentation, which is titled The Review of Laser Texturing of Titanium 6 Aluminium 4V alloy surface as an innovative method of improving the surface properties.
Good afternoon, ladies and gentlemen. My name is Monika Kraszewska, and on behalf of... On behalf of my co-authors, which is Hanna Kostyrko, Mikołaj Grabowski, Kamila Kopyłeć, I will be presenting the results of our review on laser texturing of alloys used in implantology. As you know, implantology is a very swiftly developing field of medicine with ever-rising demand. So one of the problems in this industry is treating the surface of alloys used in dental and medical implants manufacturing, so we can enhance the properties of the surface for better medical use. And the problem is that conventional surface engineering by etching, coating, and grid blasting carry a lot of risks, which are coating instability in vivo, low repeatability, corrosion risk, inflammation, poor osseointegration, and quite a lot of chemical waste. One of possible solutions to this problem is laser surface texturing. It provides high precision repeatability and is more environmentally friendly. And the aim of this study was to evaluate LST as an alternative to CSE, reflected by following indicators, which are osseointegration, corrosion resistance, biocompatibility, and changes in mechanical properties. Here you can see mainly used materials and alloys that are used to manufacture implants. And this is a systematic review that was guided by PRISMA and PICO guidelines. The analysis was focused on 9 sources regarding titanium and magnesium alloys, sourced from PubMed, Scopus databases, and Google Scholar search engine. Here you can see focus questions regarding PICO guidelines. And here are the keywords that we used in our source research, as well as PRISMA flowchart. And here is a chart that presents all of the studies that we analyzed. As you can see, one of these studies was done in vivo and the rest was in vitro. And due to this heterogeneity of the studies, we designed a tailored approach to assess the risk of bias. And overall risk of bias was found to be moderate, primarily due to the technical heterogeneity of the laser parameters. And the protocol of this study is not yet included in Prospero database. Moving, also, this is a checklist of the questions that we asked in assessing risk of bias. And now moving on to our results. Reported key factors that added to optimal parameters of the laser were short exposure time, control fluence, and proper laser type. Also, here you can see the visual effects of LST in SEM imaging, SEM microscopy imaging, which are lattice structures, roughness up to 2 micrometers, and lips, which are laser-induced periodic surface structures that look like these micro bubbles, and they have plenty of beneficial effects on the surface of the alloy. Another important factor for LST optimization was the use of inert gas in the laser chamber. In this case, it was argon, and proper post-processing of the samples. And the general results of our review was microstructural changes, laser surface area, larger surface area, better properties, and promoted osseointegration. And moving on to more specific results, here are graphs showing the effect of different laser types on the tested indicators in relation to the laser fluence, which is basically a laser strength. There was reports of the phenomenon of grouping the atoms out of the alloy. That's why we took into consideration the aluminum release risk, which is toxic. So we thought this is very important to mention. And as you can see, it is marked by red color. Also, we have HAZ, which stands for heat-affected zones. They are created within the laser treatment, around the laser treatment area, and they can have unbeneficial effects on the alloy properties. The first graph shows effects of picosecond laser. The most optimal effects are acquired within quite low fluence. And also we have very satisfactory low HAZ and aluminum release risk. Even better results are achieved within femtosecond laser with optimal fluence around 1 joules per square centimeter and almost non-existing HAZ and aluminum release risk. The worst effects was found within the use of nanosecond laser. They are described at the top, which now I see you cannot see. So this is for the nanosecond laser. So it was the effects were worsened within all the indicators. The changes in mechanical properties of titanium were surface modification without the core damage, and this was due to lip structures and lattice structure, which I mentioned earlier. And which improved the tribological properties of the alloy in comparison to CSE. And the changes in mechanical properties of magnesium are improved corrosion uniformity and structural stability of the alloy in comparison to CSE. As far as corrosion resistance, there was really, for both titanium and magnesium, formation of a more stable and more even layer of oxides, improving the desired clinical properties of the alloy, because these oxides are counter-corrosive. As far as osseointegration, LST has effects that very much improve the osteoblast adhesion up to 97%, which is really good effect. Enhanced proliferation and differentiation, and promoted vascularization due to lip structure. And additionally, there was higher protein absorption and hydrophilicity. And these effects are possible because LST enables bone mimicking structure, more specifically the lattice structure and also the lip structures. And the lattice structure is characterized by young stiffness modulus within the range typical for natural bone. So in comparison to the raw untreated alloy, the difference is quite impressive. Okay. Also, effects on antibacterial effect is very important because there was a report of lower adhesion of Staphylococcus aureus due to optimal porosity of 1 to 2 micrometers, lower biofilm formation, and hence lower risk of peri-implantitis, implant failure, and the need for a secondary surgery. Disadvantages of this method are improper parameters that can lead to higher, wider heat-affected zones with unpredictable side effects and microcracks, and also element evaporation as aluminium or vanadium. Speaking of elements evaporation, it is important to mention cytotoxicity. Potential aluminium ions release may cause neurotoxicity and also impaired bone mineralization. And this side effects is mostly caused by improper parameters, so it can be well controlled. Clinical implications of this study, we can see that it could provide longer implant survival, reduced complications, and improved bone regeneration. Limitations for the future are high initial cost of the lasers apparatus, as well as need for laser parameter optimization due to limited clinical studies. Further in vivo studies are critical because we can one day implement this method in the mainstream. And conclusions of this study is LST is a promising alternative to conventional coatings, significantly enhancing osseointegration, corrosion resistance and mechanical resistance, biocompatibility, lowering bacterial adhesion, and as well as being more environmentally friendly, controllable, and replicable. Here are our sources that we used. There are more of them than the 9 that we analyzed because we needed some extra to introduce the topic to you because it's quite complicated. Okay, so that's all. I look forward to your questions.
Congratulations, thank you very much. Very interesting topic in the era of implantology and implanted prosthetics. This is really important. I wanted to ask you about the value, the features of the rough surface of implants. When is it needed? Do we need it when we use bone level implants or bone submerged implants, or is there any difference when rough surface of the implant is meeting the intraoral cavity, for example, in peri-implantitis implants? How do you think? Is it always the advantage of the rough surface of the implant, or in some cases maybe it's just a disadvantage?
Yeah, in some cases it could be a disadvantage. That's why it's very important to characterize the parameters that are the most optimal, because the roughness from 1 to 2 micrometers is the most optimal to avoid the bacterial adhesion, because the bacteria do not have the place that they can anchor, and hence this could be an advantage in the oral cavity and also within the bone. And also these nanostructures, like lip structures or lattice structure, are beneficial not only because they improve also integration, but the lip structure also is limiting bacterial adhesion. So if properly, if we implement this method properly with most optimized parameters, this could be an advantage both in the oral cavity and within the bone.
Yeah, that's perfect. And did you find any difference in the success rate and survival rate of the implants, for example, with hydroxyapatite coated and with the rough surface prepared by laser? Did you find something in your articles that you have read?
In these studies, we did not look into hydroxyapatite coatings. We only assessed the grid blasting and etching, which can cause micro cracks, and they penetrate. They can penetrate deep within the alloy. So we only assessed the LST as a method that can treat the very surface of the alloy without damaging its core.
Thank you very much.
In your research, you have one work on vivo. It was on animal or on human?
Yes, it was on animal models. Okay, thank you very much.
Thank you very much. Now I'd like to invite the authors of the next presentation, titled Adjunctive Non-Insulin Therapies Other than Metformin in Children, Adolescents and Young Adults with Type 1 Diabetes.
Dear jury and audience, my name is Veronika Navarra, and today I will present our systematic review on adjunctive non-insulin therapies other than metformin in young people with type 1 diabetes. The key question of this work is simple but clinically important. Can we improve metabolic control in young patients with type 1 diabetes beyond insulin alone while maintaining safety? Type 1 diabetes is defined by autoimmune beta cell destruction and absolute insulin deficiency. Insulin remains the foundation of treatment, but achieving optimal glycemic control remains challenging, especially during adolescence. This slide summarizes eligibility. This creates the clinical problem shown here. Even with modern insulin therapy and glucose monitoring, many young patients do not achieve glycemic targets. Intensive insulin therapy may increase hypoglycemia risks, weight gain, or insulin resistance. So the question is not whether insulin can be replaced, because it cannot. The question is whether selected adjunctive therapies can support insulin. We focused on 4 pharmacological directions. SGLT2 inhibitors increase urinary glucose excretion independently of insulin. GLP-1 receptor agonists and DPP-4 inhibitors reduce appetite, slow gastric emptying, and may improve postprandial control. Dual agonists combine incretin pathways. So these mechanisms are promising, but safety is the central concern. Therefore, the objective of our systematic review was to evaluate efficacy and safety of non-insulin and non-metformin adjunctive therapies in individuals aged 24 or less with type 1 diabetes. Methodologically, we followed a PRISMA-based approach. We searched PubMed, Scopus, and Medline for studies published between 2015 and 2025. The initial search identified 118 records, of which 7 manuscripts were included. Data extraction was performed independently by 4 reviewers, and risk of bias was assessed using tools appropriate for each study design. This slide summarizes study eligibility. We excluded, among others, adult-only cohorts, type 2 diabetes, metformin-only studies, non-peer-reviewed or abstract-only materials. Randomized trials, observational studies, and case reports were included due to the limited evidence in younger populations. Our primary outcomes were glycemic management and safety. For efficacy, we extracted HbA1c, time in range, average sensor glucose, glucose management, and time above range. For safety, we focused on the presence of diabetic ketoacidosis, gastrointestinal events, and time below range. Secondary outcomes included body weight, BMI, kidney function, insulin dose, and glucose profiles. Overall, the evidence base consisted of 6 randomized trials, 5 case reports, all case series, and 1 retrospective study. The randomized trials mainly evaluated SGLT2 inhibitors, while case-based reports primarily included GLP-1 receptor agonists. This is not a large evidence base, but this is an important finding in itself, because these adjunctive therapies are still an emerging topic in type 1 diabetes, especially in young patients with no current routine indications. Therefore, because these studies are heterogeneous in design, sample size, follow-up, or drug class, our synthesis is cautious and narrative rather than pulled into a meta-analysis. Starting with glycemic outcomes, the most consistent positive signal was an improvement in time in range, particularly in closed-loop systems and in patients with higher metabolic burden. This is clinically relevant because time in range better reflects day-to-day glycemic stability than HbA1c, which also tended to decrease with reductions up to about 0.8 percentage points. The metabolic findings were also relevant. GLP-1 receptor agonist studies showed meaningful weight reduction of up to about 9.5 kilograms, and also an insulin sparing effect was observed, with SGLT2 inhibitors reducing total daily insulin dose by about 22%. So this suggests that adjunctive therapies may reduce both glycemic exposure and anabolic insulin burden. However, these findings come from small samples and mostly off-label use. Safety is the decisive part. For SGLT2 inhibitors, the main concern is diabetic ketoacidosis, while for GLP-1 receptor agonists, the most common adverse events were nausea and vomiting. One case series also raised a psychosocial safety signal, pathological caloric restriction, and compulsive exercise. Severe hypoglycemia did not show a consistent increase. However, the data is too limited to conclude safety with confidence. In conclusion, adjunctive therapies have shown potential metabolic benefits in selected populations of youth with type 1 diabetes receiving insulin therapy. Across studies, these therapies were associated with improvements in glycemic control, including improvement in time in range and lower HbA1c, as well as with reductions of body weight and insulin requirements in selected groups. However, these benefits require safety monitoring, particularly for DKA with SGLT2 inhibitors and for gastrointestinal or psychosocial events with GLP-1 receptor agonists. So overall, larger pediatric-focused studies are still needed to better establish efficacy and safety. Thank you for your attention, and me and my colleagues will be glad to answer your questions.
Where I could come from, because I don't find any place. Department of Children Development Medicine?
It's our university.
Katowice?
Yes, sorry.
Thank you for your presentation. A very nice presentation and fluency. Nice job. Good job.
Thank you.
Could you tell me something more about TIR, time reduction parameter, instead of A1? Because I'm the dentist and I don't know what to check in glycemic patients. Could you give me some more information?
One more time. The
time reduction parameter.
You mean time in range, right?
Yes.
So it's the time when our patient has a glycemic on the level of between 70 and 180 milligrams per.
So it's just the time. It's not a parameter,
yes,
something new, something else that I don't know. It's just the time between some points of the level. Okay.
Like from 24 hours of therapy, for example, CGM, like insulin pumps, the time that the patient exceeds or is below the criteria that we set in a clinic.
Okay, so you said it was a better indicator of the decrease of the level. Okay, now I understand.
Because it shows the fluctuations of glucose rather than the mean level.
Okay, thank you so much.
Before I raise the question, I need to see the flowchart of selected papers.
Czwarty albo piąty, nie?
No cooperation, no questions.
No, the floor.
Flowchart?
Yeah. So, again, I am a little bit confused because for the methodology you, as the flowchart shows, you included 7 studies, while for the further slides you shown 12.
Yes.
Sometimes it's inconsistent. That's the first question. The second question is about the adverse events. I know that we do not have so many studies included. However, when mentioning adverse events, it's always better to say how often the adverse events were reported, right? So, because if it was like 5%, so it wasn't nothing. But if it was like 30% or 40% patients vomited after the therapy or during the therapy, it was not good sign in my opinion. And I think the only one limitation, but that's why we included just only 7 papers, is that the topic of your review is very wide, right? You only excluded metformin, right? So my question would be why you excluded only metformin. I know that you partly explained that. However, I would rather go separately for each active substance instead of just excluding one as a possibility.
Yes, but the metformin actually has a very broad range of research in this field, especially in pediatric populations. However, our 4 groups of drugs doesn't have much, and this is also the reason why we are discussing this 5 works in like discussion factor in our work.
Yeah, I understood. So that's fine. But when reporting meta-analysis or review, you should have to be consistent. If you included 7 studies, then you show results of 7 studies. But of course, the additional 5 are considered for the discussion section.
Okay.
Thank you. Very good.
Thank you very much.
Thank you very much. And now I'd like to invite the authors of the next presentation titled A New Role for an Old Drug, Intravenous and Intranasal Lidocaine in Acute Migraine Attacks Treatment.
Yes, so good afternoon, ladies and gentlemen, dear members of the committee. My name is Emilia Jaworska, and I have a huge honor to represent the Department of Neurology from our university. And today I'll present a review to share a slightly different perspective of treating acute migraine in emergency department using widely known and used drug lidocaine. Presumably, for the vast majority of you, lidocaine is a really familiar drug as it's widely and routinely used across various medical specialties, and also it's available in plenty of forms such as gels, injections, sprays, and patches. Moving to the migraine itself, it affects approximately 1 billion people worldwide. Did you know that statistically every 8th person here suffers from migraine? Narrowing this epidemiology to the ED conditions, among all patients presenting with a headache, up to almost 32% suffer from migraine. Typical treatment used do not always effectively abort the attack, or a combination of a few drugs is necessary, so that's exactly why we decided to look for alternative options. We aim to analyze the effects of lidocaine administered in the most accessible way, so intravenously or intranasally, in terminating an acute migraine attack in a population of children and adults. We conducted a systematic review following PRISMA recommendations by searching for databases using predefined keywords. After the whole screening process, according to established criteria presented here, we finally included 14 out of 1,575 studies. We included 6 studies examining the use of intravenous lidocaine and 8 studies examining intranasal lidocaine. We included a total of 1,031 adults and 58 children, meeting the International Headache Society criteria for acute migraine or status migranosus. Included studies compared the effects of lidocaine versus placebo, non-steroidal anti-inflammatory drugs, ketamine, dihydroergotamine, chlorpromazine, and peppermint oil. Pain reduction was assessed using pertinent pain scales, and the risk of bias was assessed using proper tools. Just to make things clearer, I'll divide the results into 2 parts depending on how lidocaine was administered. So, starting with intravenous administration, here we had 325 adults and 26 children. In a study by Gur et al., intravenous lidocaine was compared with dexketoprofen, and here the authors proved that the VAS scores at the 20th and 30th minutes were significantly lower in the lidocaine group compared to the other groups. In turn, Ray et al. Compared lidocaine with ketamine, and here the pain reduction in VAS score showed statistically significant advantage of lidocaine and faster action of lidocaine over ketamine. In contrast, Reuters et al. In a very small sample found no significant effectiveness versus placebo. Our review included 2 studies comparing lidocaine with dihydroergotamine and additionally with chlorpromazine and a combination of these 2 drugs. Unfortunately, both of these studies were of low design quality and no clear advantage of lidocaine was demonstrated. Ayulo et al. Were the only authors who conducted a study in a pediatric population, and here the authors did observe pain reduction after lidocaine administration, but unfortunately did not compare those results with any control group. Moving to the adverse effects in adult population, one author reported isolated cases of anxiety, dizziness, arrhythmia, and hypotension, whereas on the other hand, in pediatric population, isolated case of chest pain and anxiety was reported. Moving to the second part, so intranasal administration, here we had 706 adults and 32 children. First authors proved a comparable significant effectiveness of lidocaine and peppermint oil, since each intervention reduced headache intensity more than placebo and provided faster relief. Comparing lidocaine versus placebo, Avco and Blanda et al. Found no significant effectiveness of lidocaine, whereas, on the other hand, Meisels et al. Did prove the significant effectiveness. In 1996, at least 50% of headache reduction was observed in 55% of lidocaine-treated people, and in 1999, a headache relief occurred in almost 36% of lidocaine-treated attacks. In a pediatric population, no effectiveness of lidocaine was proved versus placebo, and this study also was of low design quality. When it comes to side effects, for authors in both adults and pediatric population, most commonly reported local irritation of the nose or eye, such as burning, stinging, or numbness, as well as unpleasant but bitter taste. In a nutshell, intravenous administration of lidocaine showed statistically significant better therapeutic effect compared to non-steroidal anti-inflammatory drugs or ketamine. Some studies have shown a significant effectiveness of intranasal lidocaine compared to placebo, and both of these methods were associated with some mild side effects. Of course, our review has some limitations, so methodological heterogeneity of qualified research, limited sample sizes, lack of double-blind protocol, and low-quality statistical analysis in some studies. In conclusion, intravenous and intranasal lidocaine may represent promising additional therapeutic options for the management of acute migraine attacks under ED conditions. It appears to be a safe therapeutic option due to the lack of observed serious side effects, and further high-quality, well-designed, multi-center double-blind trials in the population of children and adults are needed to overcome the existing limitations, to establish standardized administration guidelines, and to determine the clinical value of lidocaine in acute migraine management. At the very end, I would love to leave you with a thought inspired by a Persian poet and a little bit my own. Don't get lost in your pain. Know that one day lidocaine may become your cure. Thank you very much for your attention, and I'll be very happy to answer any questions.
Congratulations, it's a very nice topic and a very nice issue of headache. I missed something because I would love to be in your research, a part of your research, because I'm the author of the article that is called Lidocaine Injection in Headache. Okay. So please, if you could do the same job again, if you could, because we have a very nice experience in treating something that is called temporomandibular disorder and headache attributed to TMD. That is very common, very popular, and very similar to your migraine symptoms. So I wanted to ask you if you had any questionnaire that could differentiate a migraine apart from TMD. Do you perform it in your department? And was it? I know that it wasn't in your systematic review because you did not add a keyword about TMD, and I think it should be in there.
Of course, presumably, for sure, we'll think about that. Actually, we really wanted to focus on acute migraine, so we excluded all those papers with chronic migraine, so on and so forth, because the acute migraine is a very we have to bear in mind that these people are really suffering, and the help that is available in EDs are kind of restricted or limited, as those non-steroidal anti-inflammatory drugs, paracetamol or antiemetics are not usually helping.
Exactly.
In the vast majority, so we really wanted to look for alternative in only acute migraine, but for sure,
no, you did a perfect job, and I'm very happy to hear about the old drug that is really in each clinic, in each hospital, in each dental office, and it's really fantastic to know, to talk about it, and to do more information for doctors and dentists, because we can do also injection in the field of trigger points that are doing the heterogenic pain and and referring the pain. So good job, and please publish it with our job inside.
We're looking for that. And just a commentary, we also decided to choose and look forward to Lidocaine as it's like really accessible form, and not all and because of the fact that it's like multitasking while known, so on and so forth, it doesn't require some additional like training for the doctor, some workshops, etc.
But you can get all your holistic effect of lidocaine when you are doing the injection only. So this is also important. But thank you. I was really amazed by your job. Thank you so
very
much.
Do you know anyone who have allergy for lidocaine?
Personally? Absolutely not.
I have.
Really? Oh no.
I know.
You.
I know.
All right. I thought you are the person, so I was going to say so. Now I know the person.
Okay. Yes. No. Not me, but I know.
Okay.
Thank you.
Thank you very much.
And now I'd like to invite the authors of the next presentation titled Prophylactic Negative Pressure Wound Therapy in High-Risk Abdominal Incisions.
Hello, good morning. Can I
Could you
make
share the
my
presentation,
own?
please?
Yeah, can I? Yeah, but can I make my own slide presentation?
Yes, please.
Because I've changed something. Okay, is it working?
Yes, we can see your presentation.
Yeah. Okay, everything was okay? Okay, so good morning, everyone. My name is Maria Żakowska, and today I would like to present a narrative review focused on prophylactic negative pressure wound therapy, also known as NPWT. Surgical site infections remain one of the most common complications after abdominal surgery. So, surgical site infections remain one of the most common complications in abdominal surgery. While rates are low in elective cases, they can reach up to 30% in high-risk patients. This leads to significant morbidity, prolonged hospitalization, and increased healthcare costs. Importantly, not all patients have the same risk of postoperative wound complications. Several factors significantly increase the risk of SSIs and define so-called high-risk abdominal incisions. One of the most important factors is obesity. In obese patients, wound healing is impaired because of reduced tissue perfusion, increased subcutaneous tissue thickness, and higher wound tension. Diabetes is another major risk factor. Hyperglycemia negatively affects immune function and microvascular circulation, leading to delayed healing and increased susceptibility to infection. Contaminated and dirty surgeries, especially procedures involving intestinal perforation or peritonitis, also carry a very high infection risk due to bacterial contamination. Also, emergency laparotomy are particularly hemodynamic, so they're challenging. Because patients are often hemodynamically unstable, less optimized preoperatively, and more likely to undergo contaminated procedures. And finally, midline laparotomy also. So what is this negative pressure wound therapy? It applies a controlled suction over a closed incision, and it produces edema, removes exudate, and improves perfusion. It also stabilizes wound edges, which may help also to prevent infection. And to aim of this review, was not only to assess whether NPWT works, but more importantly, to determine in which patients it provides the greatest benefits. Materials and methods. To prepare this review, we performed a literature search mainly using PubMed and Scopus databases. We focused on studies evaluating prophylactic NPWT in high-risk abdominal incisions, especially in obese patients, contaminated surgeries, colorectal procedures, and emergency laparotomies. And our search included keywords as NPWT, surgical site infections, abdominal surgery, etc. And the study selection was performed according to Prisma-based approach. That overall the available evidence remains somewhat heterogeneous. Some randomized controlled trials didn't demonstrate a statistically significant reduction in overall SSI rates when NPWT was used routinely in the abdominal surgery patients. However, meta-analyses and subgroup analyses show a more consistent benefit in selected high-risk populations. In these patients, NPWT reduced surgical site infections rates by approximately 30 to 50% compared with standard dressing. The strongest effect was observed in superficial surgical site infections. In contrast, the evidence for reducing deep incisional or organ-space infections remains limited and inconsistent. This suggests that NPWT primarily improves healing at the incision level rather than preventing deeper infectious complications. So, who benefits most? One of the most important findings is that NPWT appears to be most effective in carefully selected high-risk patients. First of all, obese patients consistently showed lower rates of superficial SSIs as seroma, also as seroma formation and wound dehiscence when NPWT was applied prophylactically. Strong benefits were observed in contaminated and dirty abdominal surgeries, particularly in procedures involving bowel perforation or peritonitis. Also, colorectal surgery is another area where NPWT appears especially useful because these procedures inherently involve bacterial contamination and higher baseline infection. On the other hand, evidence doesn't support routine NPWT use in low-risk patients where infection rates are already relatively low. And limitations of the evidence. The available evidence is limited by significant heterogeneity. There is no uniform definition of high-risk patients, and NPWT protocols vary across studies, making direct comparisons difficult. And conclusion. In conclusion, prophylactic NPWT represents a promising strategy for reducing surgical site infections, but the effectiveness depends strongly on patient selection. Current evidence suggests that the greatest benefits are seen in obese patients, contaminated abdominal procedures, and colorectal surgery. However, routine use in all patients is not supported by the available literature. Therefore, careful identification of high-risk patients is essential in order to maximize clinical benefits while avoiding unnecessary costs. That is my key references, and thank you for your attention.
Thank you very much. Are there any questions from the jury?
Did you have any own experience with such kind of patients?
Yes, because this is why I chose this topic, because I'm particularly interested in general surgery and wound healing complications. And the surgical site infections are still a major problem in abdominal surgery and in high-risk patients. And for example, my close friend had an uncle with a big, really big wound with a lot of complications with healing. And I saw that this really works. And that's why I fell into this topic and I want to know more.
Okay, thank you.
Have you considered patients with diabetes? They also have problems.
Yes, but this also, it depends from the patient, and I think about it to read more about it, to research more and more about it.
Okay, thank you.
Is that everything? Okay, thank you very much for your presentation.
Thank you so much.
Now I'd like to invite the authors of next presentation titled Pediatric Laryngopharyngeal Reflux and Laryngeal Lesions, a systematic review.
Ladies and gentlemen, esteemed jury, my name is Kamil Bronder. I am fourth-year medical student at Medical University of Silesia in Katowice, and today I would like to present our systematic review about pediatric laryngopharyngeal reflux and its laryngeal lesions. Thank you. Okay, so laryngopharyngeal reflux, in abbreviation LPR, occurs when gastric contents from the stomach refluxate backwards beyond the esophagus into the structures of larynx or pharynx. This causes irritation and this may lead to symptoms of LPR. To date, the epidemiology of this disease remains unknown. It is estimated that LPR may be responsible for 10% of pediatric laryngology visits and is probably a similar problem for both children and infants. Now I would like to highlight the difference between classic gastroesophageal reflux and laryngopharyngeal reflux. Classic GERD refers to pathological reflux to the esophagus, while LPR is a specific laryngeal manifestation of GERD, where there is inflammation of pharynx and larynx. It often presents without typical gastrointestinal symptoms. Symptoms of LPR often include hoarseness, dysphonia, Koch stridor. In this image, you can see in the left there is healthy larynx, and in the right there is inflammation caused by LPR. The goal of our study was to evaluate clinical presentation, laryngeal findings, diagnostic approaches, and treatment outcomes for LPR in pediatric populations. We performed a PRISMA systematic review based on articles published between 2015 and 2025. PubMed and Google Scholar were searched for these articles, and data quality was assessed with QA-TQS tool. There is another image of pathological changes in LPR. On the left, enlarged red arytenoids, and on the right, there is cobblestone mucosa of the trachea. Now, the inclusion criteria for our study were articles with patients aged 0 to 18 years, with reported symptoms, patients with reported GERD, laryngeal findings, diagnostics, treatment outcomes, articles mentioning disease recurrence, and full-text articles in English. The exclusion criteria were patients aged over 18 years, non-full-text articles, non-English articles. There is a flowchart of our research. First, we identified 973 articles for screening, and for the final analysis, we had 9 articles included. Our results. Main symptoms of laryngopharyngeal reflux appeared to be hoarseness, dysphonia, cough, and stridor. Otolaryngologic manifestations were edema of larynx, granulomas, interarytenoid redness, and cobblestone mucosa. For the diagnostics, were used laryngoscopy, fibroscopy, histopathological analysis, and multi-channel intraluminal impedance pH monitoring. Now, the treatment possibilities in pediatrics for this disease. Most importantly, positional therapy, diet and lifestyle change. And there are also voice therapy. There are pharmacological treatment possibilities, including the use of alginic acid, proton pump inhibitors, and prokinetic drugs. Ultimately, the surgical intervention of Nissen fundoplication is possible in severe cases. To conclude, LPR in children is associated with diverse range of laryngeal pathologies and non-specific symptoms, which may delay or sometimes even mislead diagnosis. Endoscopic evaluation remains cornerstone of the diagnosis, while treatment should be individualized. First-line management includes positional therapy and dietary modifications. Thank you very much for your attention, and if you have any questions, please feel free to ask.
Do you have access to all cited publications, to full text of?
Yes, but we forgot to put them in this presentation, but I have a list on my phone, so
okay.
Possibly I could showcase it.
While checking and reading, did you find any dental symptoms in reflux, in gastroesophageal reflux disease? Were there anything added in those materials or nothing?
Yeah, there were some mentions in these articles, but as far as I remember, none of these articles were included in our final study. The main symptoms of LPR are the ones I presented.
Okay, thank you. I was curious because we are performing a research in 100 of patients with reflux disease, and this is doctoral thesis of my doctoral student, and she did find a lot of reflux symptoms, but no reflux disease in endoscopic procedure. So this is very interesting, and this is very something I think dependent on our emotional status and stress level. So
there were some mentions about inflammation of ear. So it is possible there may be some correlations, but it's not typical presentation of this syndrome.
But very nice topic. Thank you so much. Very needed.
Thank you. Thank you.
Thank you very much. And now I'd like to invite the authors of the last presentation today, which is titled Number 6, a Systematic Review of Surgical Outcomes of Primary and Interval Cytoreductive Surgery in Ovarian Cancer. Is the author here?
Yes, sorry. My internet was a little slow.
Szósta. Tak, to jest ostatnia już tej sesji.
Can you see my presentation?
No.
Okay, so 1 second. Yes, right now?
We can see your presentation.
Okay. Oh. So we had a little sneak peek before, but dear jury, dear ladies and gentlemen, my name is Klaudia Sienko, and today I'll present a systematic review on surgical outcomes of primary and interval cytoreductive surgery in ovarian cancer. So, as we know, ovarian cancer can settle as one of the most important oncological issues in female patients, ranking as the 5th most common neoplastic process cases in Poland in 2022. Also, as you can see, the 5-year relative survival rate is around 52% in the USA. It's related to the fact that most patients are coming to the doctors in advanced stages because of lack of symptoms of ovarian cancer. The pivotal aspect in the treatment of advanced ovarian cancer is the selection of treatment, and we have the primary cytoreductive surgery, which can be the gold standard, but lately the interval cytoreductive surgery is also becoming more and more popular, but the results of this surgery still remains inconclusive. So the main question that arises among the specialists are which type of treatment achieves the highest rate of complete cytoreduction while being the least harmful to the patients, and which patients can get the most benefits from this specific operations. So we focus on identifying the groups of patients who would benefit most from one method or the other. So a systematic review of the literature was conducted according to the PRISMA guidelines to identify relevant studies, and a comprehensive search was performed across 2 databases covering the period from 2015 to 2025. We screened 394 articles and 32 records were sought for retrieval. Unfortunately, some studies had poor quality of studies or insufficient data, and we classified 11 articles for our review. The whole search strategy was structured based on the PICO framework, and we also registered our study on Prospero. So here you can see the detailed PRISMA flow diagram, and we also assessed the risk of bias using Cochrane-Robb-2 and Robbins-E. So first of all, perioperative complications were not studied comprehensively in every study, but in study by Fagotti, the randomized controlled trial demonstrated a higher frequency of these complications in PCS. Also, several studies have shown that PCS was also associated with higher short-term complications rate. According to one study, PCS was associated with a markedly longer operative time and prolonged post-operative hospital stay in the PCS, and that's why also severe early complications were relatively common. The pulmonary complications, such as pleural effusion, were also most common in this group, and they were more common than abdominal infectious or thromboembolic effects. The second outcome which was studied was overall survival rate, and patients undergoing PCS at FIGO-3 stage of cancer achieved better survival rates. Regarding the FIGO stage 4, in one study it was indicated for the first time that in this stage PCS may still show greater results from ECS, but most studies showed comparable rates. The differences between the studies mainly concern the median observation time, which was even divided by 30 months. The measurement of progression-free survival rate in most studies did not show any statistically important differences. Only one study showed that in favor of ECS, the patient survival, progression-free survival rate was about 36 months, and this was for patients with microscopic residual disease. The explanation that those results are not so different can be that the PCS patients had a very high cytoreductive rate results. So to conclude, the key factor that should be considered is the complete cytoreduction rate, which regardless of the method used is associated with increased patient survival. But overall, PCS still offers better overall survival rates, specifically for patients with good performance status. And for ECS can be a very good safety strategy for patients who have significant comorbidities and for cases where complete resection of tumors is unlikely, and those patients really common have high disease burden. Thank you very much, and I'm waiting for your questions.
Thank you very much. Are there any questions?
I have a question. So while reporting 11 studies, is that right? I would love to see the sample sizes of those clinical trials, because showing the different effects, right, within the percentages, it would be great to see how big the sample sizes in the clinical trials were. And this is I think the biggest limitation of this well performed, actually, because it was the first time during that session that someone presented PICO, which is one of the criteria for the systematic review. Thank you.
Yeah, so I just wanted to add that we included randomized controlled trials and also observational studies, and those observational studies had a very high number of patients, because sometimes it was thousands of patients from national databases. But yeah, it's very good thing to include next time.
Any own experience in clinics with such patients that?
Yes, so I'm a member of the student association, and during the past few months when we were studying this subject, we also had a possibility to assist on the operations for this kind of patients. And this is a very huge problem, because a lot of patients are older patients, and most of them have also some long-time diseases like obesity or diabetes, and that's where the decision between choosing the type of treatment is getting much more harder.
Thank you.
Thank you.
Thank you. So that's all then. Okay, so I believe all the presentations in this session have been presented. Thank you very much for your engagement. I'd like to once again thank the esteemed jury for giving up their time today. It's been a very long session. Thank you very much. Can we have a round of applause for the jury?
So just for the end of the session, I would like to say big thanks for the presentations. The quality were really impressive, and I think every single year we see that as a students you improve, and I love to participate in a SIMC conference. Thank you. Yeah.
So this is formally the end of the session. Thank you very much for attending again.